Hi everyone, it's Dr. Fox, and let's talk about the innervation of the orbit. In this video, we'll diagram the somatic and autonomic innervations of the orbit and of the eye. So let's start with cranial nerve 2, the optic nerve. The optic nerve travels from the retina of the eye, posteriorly through the orbit, through the optic canal, back to the optic chiasm. The optic nerve is carrying special sensory information from the eye and is responsible for vision. Next up, let's talk about the three cranial nerves which are responsible for the extraocular muscles. They are the oculomotor nerve, the trochlear nerve, and the abducens. So the oculomotor nerve, or cranial nerve 3, is responsible for all of the extraocular muscles with the exception of superior oblique and lateral rectus. Oculomotor controls levator palpebrae superioris, superior rectus, medial rectus, inferior rectus, and inferior oblique. And in addition to doing all of that heavy lifting, it also conducts the preganglionic parasympathetic fibers to the ciliary ganglion of the orbit, which then postganglionic fibers are going out to the sphincter pupillae muscles, those which are responsible for the constriction of the pupil, as well as the ciliary muscles, which are responsible for accommodation. The oculomotor nerve arises from the midbrain, and it travels between the posterior cerebral artery and superior cerebellar artery. The issue here, and we can see this right there, is that any aneurysm of either the posterior cerebral or superior cerebellar artery is going to compress the oculomotor nerve, and therefore it is vulnerable to an aneurysm. If this should occur, one of the earlier symptoms is going to be diplopia, or double vision, because it's going to affect the oculomotor nerve's ability on one side of controlling the extraocular muscles. Cranial nerve 3 is also present within the lateral wall of the cavernous sinus, and if there is a cavernous sinus thrombosis, it may also be susceptible there, but the number one cranial nerve that you should be looking out for if there is a cavernous sinus thrombosis is the abducens, because it travels through the cavernous sinus and would be therefore affected first. After moving through the lateral wall of the cavernous sinus, 3 is going to enter the orbit through the superior orbital fissure. Next up, the trochlear nerve, cranial nerve 4. Its claim to fame is that it is the smallest cranial nerve and the only cranial nerve to arise from the dorsal brainstem. It also travels within the lateral wall of the cavernous sinus and is therefore susceptible to a cavernous sinus thrombosis, but not as susceptible as the abducens. And it enters the orbit through the superior orbital fissure. It only innervates one muscle, and that is the superior oblique muscle. The superior oblique muscle has a tendon which goes through a cartilaginous pulley called also the trochlea, so it is easy, therefore, to remember that the trochlear nerve innervates the superior oblique muscle. We're going to skip cranial nerve 5 for the time being and continue on with discussing the cranial nerves responsible for the extraocular muscles, rounding out our trio with the abducens nerve, or cranial nerve 6. The abducens arises from the brainstem, travels directly through the cavernous sinus, and enters the orbit through the superior orbital fissure. Because of its path through the cavernous sinus, that makes the abducens nerve most susceptible to a cavernous sinus thrombosis, the earliest clinical sign of which would be the inability to abduct the eye. Abducens innervates exactly one muscle, and that is the lateral rectus muscle, and abducens abducts or moves the gaze laterally. Let's go back and hit cranial nerve 5, specifically V1, or the ophthalmic division of the trigeminal nerve. The ophthalmic nerve is responsible for afferently serving the orbit, the eye, the lacrimal gland, and the skin around the orbit, or the periorbital skin. It is not responsible for the process of lacrimation. That's going to be due to the facial nerve, as we'll see. The facial nerve, or cranial nerve 7, has many different responsibilities of all of the muscles of facial expression. It also innervates orbicularis oculi, which is going to control the palpebral fissure. It is also going to provide the preganglionic parasympathetic fibers to the pterygopalatine ganglion, which we can see here in the pterygopalatine fossa. So those preganglionic fibers come from the facial nerve within its osseous canal. Postganglionic fibers are going to hitchhike with branches of V2 to serve the lacrimal gland. When there is parasympathetic stimulation from the facial nerve, this is going to increase lacrimation or tear formation. Now let's look specifically at the autonomics of the eye to review. There are two sources of autonomics to the eye: the oculomotor nerve, cranial nerve 3, and the superior cervical ganglion of the sympathetic trunk. The oculomotor nerve is what is responsible for the preganglionic parasympathetic fibers serving the ciliary ganglion. The ciliary ganglion is located there in the orbit, just inferior to the optic nerve. And postganglionic fibers from that ciliary ganglion are going out to sphincter pupillae muscles, which will constrict the pupil, and to ciliary muscles, which are responsible for accommodation. So during a parasympathetic response, one should expect constriction of the pupil. Contrast that with a sympathetic response. Fibers from the sympathetic trunk, specifically from that superior cervical ganglion, are going out via perivascular plexuses, and they are going to innervate the dilator pupillae muscle, which is responsible for dilation of the pupil. So during a sympathetic response, the pupil will dilate. Also during a sympathetic response, we should expect to see vasoconstriction of the vessels of the orbit. Thank you so very much for your time, and I look forward to talking to you in the next video.